So welcome to the next episode of Endoscopy Essentials. We are in the middle of early rectal cancer with Barbara Bastiaansen. Welcome back. Last time we left you with, all the preparatory steps, how to assess early colorectal cancer, what the definition is, etc., etc. Now the big question comes up, which endoscopic techniques do we have? Because the big hype is still ESD, endoscopic submucosal dissection.
Yeah.
So is that a good technique for early rectal cancer, or?
It's a beautiful control technique compared to snare. It's a beautiful technique, and we all know the pictures and the good things about ESD. You can unblock resection no matter the size, and I think it's perfect for large rectal lesions who have quite a big risk of having covered submucosal invasion. And then it's beautiful to get an unblocked resection, and in case of that 10% that it turns out to be a cancer, you have a good chance of being curative, because it leads to a high R0 resection rate in experienced hands for non-malignant or early invasive cancers. But there's also a big problem with ESD, and to be honest, I fear that the submucosal plane for cancer is not good enough. I think the submucosal plane really limits histological assessment and the quality of the specimen. And what we also should know is that the majority of T1 colorectal cancers, that we see, have deep submucosal invasion at diagnosis. So up to 75. So you have to be very lucky to encounter a superficial invasive cancer that really look like cancer, huh? Because I always tell everybody, if it really looks like cancer, it's not an SM1 anymore. Usually it's not an SM1 anymore.
There are a lot of very important messages in what you said. You said covered cancer.
Yeah.
So that means it's primarily a benign lesion.
Yes.
Where some parts are suspicious for at least high grade, if not very early cancer. And let's remind our audience there's no mucosal cancer in the colorectum. So cancer starts in the submucosa. So that's the type of lesion with a high expectation that the maximum histology is high-grade dysplasia. That's the type of lesion you would favor ESD, right?
Exactly.
But when you know it's cancer, hands off with regards to ESD?
In many cases, I think so. This is an example on this slide. This was a big granular lesion, as you can see. This was the sigmoid. This was the ventral part of the sigmoid, so not a lot of playing room. In the rectum, we would go into the muscle if necessary, but this is the sigmoid, and you don't want to make a perforation in a cancer. So this was a lesion, as you can see, there's a very, very tiny part of invasion. All the rest in the periphery looks completely benign.
Which you only see at close up.
Yeah. And it was the focus was really small, like 4 millimeters or so. So I thought, let's have a go. This is just an example, but so we started ESD in the periphery, nice lift, you can get nice access to the submucosal plane, but then underneath that little central part, you see already what we call the muscle retraction sign. You see this triangular shape of the muscle being torn into the invasive part, and then we are in the sigmoid. You don't want to make a perforation, so you difficult, but you stay just above the muscle. You can get it out completely, unblock but then histology comes back, and then you have the problem that the deep resection plane underneath that part of invasion is not clear. And that very often happens in T1 cancers. If you critically look at data on ESD for cancers, because the vast majority of all data that we have on ESD is for benign lesions, right?
And some with some small little very superficial cancer.
Exactly, but the majority is for benign lesion. But if you critically look at data for actual cancers, we see that the R0 resection rates are really dropping. And as soon as the invasion is SM2 or more, then the R0 resection rate drops to
game over.
Yeah, it's unacceptably low for cancers. And that's the problem, as you can see here in the, of course with ESD, you cut in the lower third of the submucosal plane, and then you run into problems already from SM2, depth of invasion. And that's what studies also show, that as soon as you have a deep invasive lesion, and remember that's in the majority of the cases that's the case, and then you lost your curative resection because you don't have an R0.
Mm-hmm.
It starts with an R0. Organ preservation starts with a good quality specimen.
Right. You say submucosal invasion is often deeper, as we can see on this slide. And
yes,
this shows 70% SM2 and more.
Yeah, this was a study where they analyzed non-curative ESD for cancers, and they had over 200 lesions that were non-curative ESD for a cancer, and then they looked like, okay, what was the reason for being non-curative? And you see already here that 70% of all those cases of ESD, and I think those ESDs were performed for the suspicion of superficial invasive cancer, otherwise you maybe wouldn't start ESD. And then even then you see 70% deeper invasive lesions. And then if you look further at the R0 resection rate in this study was 35%. Yeah. So the question is the submucosal plane, is that really good enough for cancer, or do we need at least a part of the muscle to have a better quality histology and a better chance for a complete excision? Yeah.
Well, I couldn't agree more, to be honest. But if we are a little bit mean to our ESD colleagues, we would say that in known cancer, ESD is a systematic undertreatment.
I'm afraid it is in many of the cases, yes.
So let's see how much we get beaten up. But I think the distinction is also very important, as we said. If it's a benign lesion where you are not sure about some areas, then ESD is okay. If it's frank cancer, all over the place anyway. But if you know that there is cancer and it's biopsy proven or whatever, you should really reconsider. Is that correct?
Yeah, that's correct.
Okay.
And I think it's also fair enough to say that big lesions that look benign but have morphological criteria with a higher risk of unexpected cancer, like a big nodule in a mixed granular type lesion with a big nodule, I think ESD is perfect. But as soon as exactly what you say, if you have a big clear part of invasion, then we.
Well, there's this big battle ongoing in the colon, right? But we stay away from the colon for this podcast. Whether ESD should be systematically done, but again, the discussion covers mostly benign or early malignant lesions. So back to the rectum, we decide ESD is not the ideal treatment and not the best weapon. Okay, we get that. So above the rectum or proximal rectum, maybe you can show us quickly how this procedure is performed in the softer lesions, in the suitable lesions.
Yes, sure. So endoscopic full thickness resection and the FTRD system is the only system that integrates tissue resection and closure of the perforation in a one-step integrated procedure. So it's very important, of course, we follow the right sequence of steps of the procedure. So first of all, we need to recognize the lesion, which can be difficult with the long cap because it takes a lot of light and visibility. So marking of your target area is, you think it's not important, but usually it's important to recognize the right spot.
That's a very important message, because if you see a lesion clearly with your super endoscopes, you think, I don't need to mark.
No.
But then you go on with this huge cap, you have collected a little bit of dirt higher up in the colon and you see nothing.
No, that's right.
So that's very important.
So markings can really help. So that's important. Without the long cap, of course. So it's always several procedures. The first one you go in with for the markings, then you build the FTRD system, you go to your target lesion, and then through the working channel the grasper is being advanced, which can only be opened outside the cap because the grasper is quite big, and if you open it inside the cap you can dislodge the snare which is in the top of the cap. But you grasp the lesion and then you slowly pull the lesion into the cap, and in the perfect procedure you will see all the lateral markings entering your cap, but in realistic procedures you don't always see the markings clearly come into your cap, but you see the popping of your target area into your...
And if you pull very effectively, you see nothing. Because the lesion is very close, huh?
Yeah, that's right. And then you have to be careful, because if you completely fill your cap and you don't see this white ring, which is very important, that you see that, because the tactile feedback of your clip being released, which is essential before you start cutting, of course. Otherwise, we have a 4 centimeter perforation. You wouldn't want that. So if you fill your cap completely with tissue with additional aspiration, you just push your tissue out a little bit with the grasper, so you can see the right ring. Then the clip is being released by turning the hand wheel. You see the white ring being pushed forward, as you can see here. And then you know the clip is released, and then only then, of course, we cut the tissue. And then it's always in the perfect position from the clip, of course.
When do you close the snare?
You close the snare when you're fully sure that the clip is off. And if you are in doubt, you just give it another turn.
Because otherwise the snare is
no.
entrapped?
No.
If you close the snare before? I've heard some people say,
that's
because
right.
the snare tends to slip off, sometimes I close early and then...
I don't have experience in doing that, but that's right. Some people, to entrap the specimen, close the snare. I think it's kind of tricky, because if you get dislodged or somehow something changes in the position of your endoscope... If
it slips out a little bit, then it's entrapped.
You have yeah.
And you said aspiration, it's usually forbidden, we are told.
Of course, there's always this theoretical risk that with aspiration you will entrap adjacent organs like a ureter or small bowel loop. But to be honest, I think it is important not to start with suction immediately. But if you fill your cap with a little bit of tissue, most often you do need some additional aspiration to get everything in. But
especially
I think it's
in the harder lesions. Huh?
Okay. You do need some aspiration, but don't start with aspiration. I think then...
Good.
Yeah.
That was full thickness in 2 minutes.
Yeah.
And we have a size limitation, and in our favorite organ, the rectum, we also have a hardness limitation or pulling limitation. So now finally, at least we start the next step, your procedure, intermuscular dissection.
Yes, the rectum is of course perfect for endoscopic intermuscular dissection, because the muscle layer in the rectum is so well developed. You can really differentiate and split the inner circular from the outer longitudinal. And there's a real clear plane, the intermuscular plane, which is not there if you move higher up. I mean, if you're very proximal in the rectum, it gets a little bit difficult to find the intermuscular plane, and I think we cannot do this outside the rectum because we will make huge perforations. But in the rectum, it's a real new plane. I mean, you can expand it. You can also even make it like a submucosal plane, but it can be easily divided. You just.
So if you are, these are very nice pictures where you see where the two muscular planes are, right?
Yeah.
You very briefly mentioned, here we are, right?
Yeah, so this is the intermuscular plane, huh? And the inner circular muscle is the thickest. The longitudinal muscle is quite thin, but still it preserves the outer wall layers if we stick to the intermuscular plane. Yeah,
and you can see it also on the endoscopic images, right?
Yeah. So here is here's the cut of the inner circular muscle. So it's a selective myotomy of the inner circular muscle, and we're exposing the outer longitudinal muscle. Yeah.
You were mentioning, I think very briefly in another podcast, how the strategy is. Because one would think, okay, I do an ESD, and if not, I just go deeper.
Yeah.
But you also told me that this is a little bit risky because it might be too late.
Yeah, that's what our early experience was, okay, we start ESD and we'll see when it gets difficult, then we do the myotomy. But very often we found out that it was then too late, then your R0 section drops. If it gets difficult, then you're usually too late. So, and it's much easier if you start the intermuscular dissection already at the edge of the lesion. So you have the full muscle layer underneath your invasive front to also deliver the best histology. And the intermuscular plane is a nice plane. It's relatively avascular. Of course, you have to be careful for the big, branches, the perforating vessels. But once you find it, it's a relatively easy plane.
And it's also logical what you say, because at the mucosa, everybody understands we have to have a safety margin.
Yeah.
But the same is true for the muscularis.
That's right.
Yeah, around the tumor, you have to have a safety margin of normal muscular layer, right?
Yeah.
So that's why you should do deep diving earlier and not too late.
That's right.
Then you lose your R0 advantage.
Chance. Yeah, that's right.
Good. Okay. So this was a very nice introduction into the technique, going deeper and deeper, or using different techniques. But there's probably also a lot of logistics around. So any comments about which scope, colonoscope, gastroscope, which channel, caps, knives?
Yeah. Well, basically, it's just an adaptation of the ESD procedure. So there's not any specific accessories that you need compared to regular ESD. It's nice to have we always use a gastroscope in the rectum, so it's easy to read reflex. You need a 2.8 working channel just in case you need a co-grasper. You don't need a 3.2 working channel. You don't need a therapeutic gastroscope. A short cap, I think, is important. I like to work very close because the plane, of course, is very narrow. So I even like to work in near focus mode, and a long cap can prevent that. So just a 4 millimeter cap is long enough. We use just a straight short cap. It's nice to have a precise knife, which, of course, a 1.5 millimeter knife is really the longest you can have, because even that you cannot use the full knife to stay in the intermuscular plane, because then you'll hit the longitudinal muscle. We do this procedure mostly as an outpatient basis. So patients are of course 1 hour in observations after deep sedation, and then
no general anesthesia.
No general anesthesia.
Okay.
No.
So the normal propofol thing, like
exactly.
a big EMR.
Yeah.
And outpatient. Okay.
Outpatient, yes. Yeah.
That also means the defect is not closed or not treated with a sponge or anything normally?
No, that's right. In the beginning, when we had sometimes longitudinal muscle injury, or when you have a big perforating vessel, there's a natural opening in the longitudinal muscle where you see the mesorectum, of course. We used to be very enthusiastic about closing that, but it turned out not to be completely non-necessary. So we are now, if we have a transmural defect, we won't close. Actually, like the surgeons do in their transanal surgery, which they make big transmural defects without closing. We are covered by the mesorectum, and there's also beliefs that if you close, you even maybe stimulate abscesses formation, because you
leave some dirt outside, and
exactly.
then you insufficient drainage.
Yeah, I think one important thing is that we rinse the defect very thoroughly. Also, there's a belief that if you rinse, you prevent tumor cells seeding into the mesorectum, for example. But so even in transmural defects, patients are usually not admitted. If it's a very big defect, then we continue antibiotics for 5 days. But
otherwise, it's a single shot?
It's a single shot,
okay.
Yeah, during the procedure.
So almost like ESD?
Yeah, that's right. Yeah.
Okay. Thank you very much for that introduction. Of course, that's not all. So we'll come back with more details about EID, how it looks like, what you have to avoid, and then finally about the results. Thank you very much, Barbara.
Thank you, Thomas.